Good morning, everyone. I am Dr. Brish Makkar from New Delhi, India. I am a practicing diabetologist and a bariatric physician, and my area of interest is not only diabetes bariatrics, but of course the emerging technologies in the field of diabetes and obesity. And this is a very important session. CGM in pregnancy is very, very important session because we know pregnancy is a very crucial phase in the life cycle of every single woman. And those living with diabetes, maintaining a very good glycemic control is of utmost importance to have good outcomes of pregnancy. And we are trying to do all the time everything that can help a woman achieve a good glycemic control and have a normal outcome in pregnancy. And that's where this session is very important. To chair this session with me is a very senior professor from Argentina. I am pleased to present Professor Silvia Lepatosa, who is here with me. She is a nutrition and diabetes specialist and PhD in medicine from National University of the Northeast of Argentina. She has worked for 30 years in diabetes and pregnancy and is a professor of Northeast Medical School and served as president of Argentina Diabetes Society from 2020 to 2022. She is a member of Diabetes Masters Academic Committee and a member of Education Working Group of the Saka region of IDF. She coordinates the Diabetes and Pregnancy Research group for the Latin Diabetes Association, and her area of interest is diabetes in pregnancy and health education. That's where she is from. So, over to you.
Thank you. Introduce co-chair, Dr. Bid Mohan Makkar, is a senior diabetes physician and director of the Diabetes and Obesity Center in New Delhi, India. Is currently the president of the Research Society of the Study of Diabetes in India. Is the recipient of numerous awards. He has published extensively, including chapters on diabetes and obesity. Dr. Makkar was instrumental in formulating the first Indian guidelines blood glucose monitor. I introduce the first speaker, Dr. Katrin Benamima. Is a staff member of the Department of Endocrinology at the University of Leuven and associate professor in Belgium. He has a senior clinical research fellowship from the Flemish Research Council. She is the principal investigator of several studies, including the CRYSTAL study on the MiniMed 718 system in pregnancy complicated by type 1 diabetes. She is actively involved in the diabetes pregnancy study groups associated with the European Association of Diabetes. She won several awards. Thank you, Doctora.
Thank you very much for this nice introduction, and thank you very much for being here early this morning. I think it's very timely indeed to discuss the use of newer technologies in pregnancy, because we know that automated insulin delivery systems are used more and more often as standard of care for the management of people with type 1 diabetes, and so more and more women will become pregnant using these systems. I will present you data from the CRYSTAL trial. This was an investigator-initiated study on the 780G system in pregnancy. It was funded by the Flemish Diabetes Liga, so the association representing people living with diabetes, and we also received a grant and study devices from Medtronic for the study. Now, we know that women with type 1 diabetes are still at increased risk for pregnancy complications. They have a higher rate for congenital malformations. About half of all babies are still born larger gestational age, and they are also at increased risk for preeclampsia and preterm delivery. Now, we know from the CONCEPT trial, which evaluated real-time continuous glucose monitoring in type 1 diabetes pregnancy, that it leads to improved glycemic control at the end of pregnancy compared to capillary glucose monitoring. So time in range was 68% in the group using CGM compared to 61% using capillary glucose monitoring. And this translated into improved pregnancy outcomes. So there was a lower rate of large gestational age infants, 53% compared to 69%, And there was also a lower risk for neonatal hypoglycemia and for the need for admissions on the NICU, so the neonatal intensive care unit, with a low number needed to treat between 6 to 8 to prevent one adverse pregnancy complication. But at the same time, we know that despite the use of CGM in pregnancy, for many women it remains challenging to achieve and maintain the tight glycemic control we aim for in pregnancy. So we aim for a target range between 63 and 140 milligrams per deciliter more than 70% of the time. And often in many women, this is only reached in the final weeks of pregnancy. Now, we know from outside pregnancy, non-pregnant populations, that the use of advanced hybrid closed-loop systems have really led to a paradigm shift. Time in range is on average 12% higher compared to conventional pump therapy. And so these closed-loop systems are now increasingly used as a standard of care for the management of type 1 diabetes outside pregnancy. And so more and more women of reproductive age are becoming pregnant using these systems. Now, currently, only the KMAPS system is licensed for use in pregnancy. So all the other commercially available closed-loop systems have not been tested or are not licensed for use in pregnancy. So we also need evidence on the safety and the efficacy of closed-loop systems that have not officially been approved for use in pregnancy. So here I provide you an overview of the different RCTs that have evaluated closed-loop systems in pregnancy. So first there was the ADAP trial, a large RCT from the UK, published in the New England Journal of Medicine in 2023, evaluating the KMAPS system compared to standard of care, so multiple daily injections or open loop pump therapy. And I will go to more detail later on this study. Then there was a PICKLE study. This was a small pilot RCT performed in the US, comparing the Medtronic 670G system compared to open loop pump therapy. But as you know, the 670G system has a non-customizable glucose target, so you cannot lower the glucose target below 120 milligrams per deciliter. And so this leads to higher mean glucose values in the third trimester compared to open loop pump therapy. And so this is not often used in pregnancy, so I will not go into more detail into the PICKLE study. And we in Belgium and with one center in the Netherlands, we performed the CRYSTAL study, a large RCT comparing the Medtronic 780G system compared to standard of care, so open loop pump therapy or multiple daily injections. And then the CIRCUIT trial evaluated the tandem control IQ system compared to standard of care. The study was completed recently, and the results will be presented at the ADA later this year. So if we then first have a look at the ADAP trial, so it evaluated the KMAPS system, which is currently the only AID system licensed for use in pregnancy. So it uses the algorithm is based on an Android app, and soon it will also become available with iOS. It's mostly used with the MyLife Ipso pump, and both rapid and ultra-rapid insulin analogs can be used with this pump. It's the only algorithm that provides fully customizable glucose targets, so the glucose target can be lowered up to 80 milligrams per deciliter, which is of course very useful in pregnancy when we aim for very strict glycemic control. So it is recommended in the first trimester to use a glucose target of about 100 milligrams per deciliter due to the increased risk for hypoglycemia earlier on in pregnancy. And then from the second trimester onwards, the glucose target can be further lowered between 80 and 90 milligrams per deciliter. So in the ADAP trial, this was a multi-center RCT from the UK. So women were included with a hemoglobin A1C at baseline between 6.5 and 10%. So the KMAPS system was compared to standard of care, so open loop pump therapy or MDI, and 124 women were randomized in the study and included before 14 weeks of pregnancy. And the primary outcome of the study was time in range for pregnancy. If we first look at the baseline characteristics, there was a mean hemoglobin A1C at baseline of 7.7%, and about half of the population was using MDI. Now, women who were randomized to the closed loop arm are indicated in red, and in blue is the standard of care group. And what you can see is that women randomized to the closed loop arm in red, so within 1 week after randomization, had an improved time in range. So the time in range was 10% higher in the closed loop arm compared to the standard of care group. So on average, a time in range of 68% was achieved in the closed loop arm compared to 55% in the standard of care group. And there was a lower time above range, a 10% difference in women using the closed loop arm, and the time in range overnight was 12% higher in women using the closed loop arm compared to the standard of care. And importantly, this was achieved without increased risk for time below range. So very important data indicating that the use of a closed loop system in pregnancy can lead to improved pregnancy outcomes, better glycemic control. Now, as with all the other RCTs, the ADAPT trial was not powered for pregnancy outcomes, but of course it's still important to look at the pregnancy complications. The rate of any hypertensive disorder was significantly lower in the closed loop arm, so gestational hypertension or preeclampsia combined. There was a high rate of C-sections in both groups, so both in the closed loop arm and the standard of care group. And the maternal gestational weight gain was significantly lower in women using the closed loop arm compared to the standard of care group. Recently, a few weeks ago, the ADAPT postpartum extension study was published in Lancet Diabetes and Endocrinology. So about half of the women who participated in the RCT could be followed up 6 months after the delivery. So women in the closed loop arm continued to use the KMAPS system, and women in the standard of care group just continued to use MDI or open loop pump therapy. And what you can see is actually that the group that continued to use closed loop postpartum had a much better time in range, and this is the non-pregnancy time in range, so between 70 and 180 milligrams per deciliter, 72% in the closed loop arm compared to 54% in the standard of care group. So continuing closed loop therapy in the early postpartum really helps women to maintain this tight glycemic control. And postpartum, the glucose target used with the algorithm was on average 109 milligrams per deciliter, so of course higher compared to what is used in pregnancy. ESOF was used as needed, meaning that the glucose target can be increased with 45 milligrams per deciliter if needed. Of course, postpartum, the insulin to carb ratio needs to be increased, 1 to 12 or even 1 to 15 if women are breastfeeding. And with this system, it's also important to adjust the weight again to pre-pregnancy booking. So this was first the results of the ADAPT trial evaluating the only closed-loop system licensed for use in pregnancy. But as mentioned, there are many commercially available closed-loop systems, and women are also becoming pregnant using systems that were not tested for use in pregnancy. And this is why we evaluated the 780G system in pregnancy. So this is officially not approved for use in pregnancy. And we performed a crystal trial in 11 Belgium centers and in 1 center in the Netherlands. So the 780G system is includes an algorithm that automatically adapts the basal insulin rate every 5 minutes and also provides automated insulin boluses to correct for hyperglycemia. And it offers customizable glucose targets, so the lowest glucose target that can be used is 100 milligrams per deciliter. So in the crystal trial, women were screened before 12 weeks of pregnancy, and there was no under limit in hemoglobin A1C for inclusion. So also women with a hemoglobin A1C below 6.5% could participate in the study. If women were already using a closed loop system before pregnancy, they had to switch to manual insulin delivery as soon as pregnancy was confirmed. So after the screening visit, this was followed by a run-in phase, and women were then randomized 1-to-1 to either the standard of care group, where they continued with open loop pump therapy or MDI, or they were switched to the intervention group, so the 780G pump, and women were followed up until the hospital discharge after the delivery. So we use the most strict settings to be used throughout pregnancy with this pump, so a glucose target of 100 and active insulin time of 2 hours. To limit the risk for postprandial hyperglycemia, it's of course important to optimize the insulin to carb ratio, to limit the intake of carbohydrates with high glycemic index, and to be aware of the safe meal bolus. And this is really something specifically for this algorithm. So if the algorithm predicts hypoglycemia within the next 4 hours after the meal, it will reduce the bolus as a feature of safety. It's not something you can turn off. So at some point, if safe meal bolus occurs, you cannot further reduce the insulin to carb ratio because the algorithm will just further reduce the bolus. So when this occurs, women were recommended to provide assisted carbohydrate estimation, meaning that they had to add fake carbs with the meals, and this is a way to assist the algorithm to increase the bolus, and I will give you an example later on. So if we first look at the baseline characteristics, in contrast to the ADAPT trial, our population was better controlled at the start of pregnancy, so there was a mean hemoglobin A1C of 6.5%. All women were already using CGM before the pregnancy, and this is because this is freely reimbursed for all people with type 1 diabetes in Belgium, and the majority was already using a pump, and 96% was using a pump, mostly sensor-augmented pump therapy with predictive stop before low, and the baseline time in range was 59%. If we then look at the main outcomes, so the primary outcome was time in range for pregnancy. This was not significantly different between both groups, so this mean time in range of 66.5% was achieved in the 780 group and 63% in the standard of care group. The study was also powered on several key secondary outcomes, and these were better in the 780 group, so the time in range overnight was significantly higher in the 780 group with a difference of 6.5%. And the time below range overall and the time below range overnight was significantly lower in the 780 group compared to the standard of care group. It was safe to use the 780 pump throughout pregnancy. There was no difference in the rate of severe hypoglycemia. There were no hospitalizations for severe hypoglycemia in the 780 group and 5 in the standard of care group. And there was 1 hospitalization for DKA in each group, but this was not related to the device. This was due to a severe COVID infection. Women using the 780G group reported higher treatment satisfaction and also less hypoglycemia and awareness compared to the standard of care group. So as with the ADAPT trial, the Crystal trial was not powered on pregnancy outcomes, but there was no signal that outcomes were worse in the 780 group compared to the standard of care group. For instance, the total number of cesarean sections was nearly 49% in the 780 group and 64% in the standard of care group. Excessive gestational weight gain was significantly lower in the group using the 780 pump compared to the standard of care group. There were no differences in neonatal outcomes, and the rate of NICU admissions due to neonatal hypoglycemia was significantly lower in the 780 group, 14%, compared to 63% in the standard of care group. Now, as I explained, women were recommended to provide assisted carbohydrate estimation in case safe meal bolus occurred, and this was often needed in pregnancy, as nearly 61% of all women used assisted carbohydrate estimation starting on average 19 weeks in pregnancy, and so when the insulin resistance starts to increase, and on average 73% of fake carbs was added with the meals. And here I will present you an example. So this is a participant in the study. She's 18 weeks pregnant. So we use the most strict settings possible with this pump. So a glucose target of 100, active insulin time of 2 hours. And you can see that she's not well controlled. That she has a lot of postprandial hyperglycemia. Time in range is only about 50%. And so the issue here is really the safe meal bolus. So the algorithm provides less bolus than what you would predict based on the insulin to carb ratio. So by further reducing the ratios, you will not increase the bolus. So how to handle this? It's often better to slightly increase again the insulin to carb ratio, and at the same time recommend women to add fake carbs with the meals. So in this case, we started with 50% extra. So if she eats a meal of 40 grams, she has to insert 60 grams. And by doing so, this really assists the algorithm to increase the bolus again. So this is something you need to know when this pump is used in pregnancy, that assisted carbohydrate estimation is often needed. Some other practical tips when using this pump. So it's recommended to bolus 10 minutes before meal, also later in pregnancy when there is delayed absorption of insulin, 10 minutes before the meal is enough. And by bolusing too long in advance, it can also increase the risk for safe meal bolus. Also, when women are already low before the meal, or when there is a sharp drop before the meal, it's recommended to only enter the bolus when they start eating. So when the glycemia starts to rise, this helps also to decrease the risk for safe meal bolus. So in the meantime, we are currently looking at who might benefit most from using the 780G pump in pregnancy, because the overall time in range was not significantly different. So we are currently looking at different subgroups. This is work in progress, so it's not yet published. So I would appreciate if you could not take any photos of the next slides that I will present you. So we will be looking now at baseline characteristics, so based on baseline hemoglobin A1C, based on whether we were already using a closed loop system before pregnancy, and based on the level of education of our participants. So if we first look based on baseline hemoglobin A1C, the majority of participants in the study had a hemoglobin A1C below 7% at baseline, and actually in this subgroup we do see a significant increase of time in range overall, with a difference of 5% higher in the group using the 780G pump. So this means 1 hour and 20 minutes of improved glycemic control. Also, the time in range overnight was nearly 12% higher in women using the 780G pump in the group with a lower baseline hemoglobin A1C. And the time below range overall and overnight was also significantly lower in women using the 780G pump and starting with a lower baseline hemoglobin A1C. If we look at differences in characteristics between the group who was well controlled already at the start of pregnancy and women with a higher baseline hemoglobin A1C, there was no difference in age or in BMI, in gestational weight gain. As can be expected, women with a lower baseline hemoglobin A1C had significantly more often a planned pregnancy, and in the control arm also used already more often a closed loop system before pregnancy. But an important difference is actually that women already with a lower hemoglobin A1C at baseline used assisted carbohydrate estimation more often than women with a higher baseline hemoglobin A1C, which might suggest that these women are more proactive, more engaged in managing this, their diabetes, and this might in part also explain why we do see an improved time in range with the 780G group in this subgroup. Next, we also looked at, based on whether they already used a closed loop system before pregnancy, about 43% of all participants was already using a closed loop system before pregnancy, mostly the 780G pump. And actually, it's in women who were not yet using a closed loop system before pregnancy that by switching to the 780G pump, we do see a significant increase in time in range overall, 6%, and also the time in range overnight was significantly higher, nearly 12%, and the time below range overall was significantly lower in women using the 780G pump in the group that was not already using a closed loop system before pregnancy. And if we then look at the level of education of participants, it's actually the group without higher education, so women who did not have a bachelor or a master degree after high school, that seemed to benefit most from switching to the 780G group, because time in range overall was significantly higher, with 7% difference with the standard of care group in women who did not have higher education and used the 780G pump in pregnancy. The time in range overnight was significantly higher in the 780G group, irrespective of the level of education, and the time below range was only lower, significantly lower in the 780 group in women with a higher level of education. Very recently, a few weeks ago, we published an economic evaluation of the Crystal trial, so looking at the cost effectiveness of the intervention, and this was published in eClinical Medicine. So we made a very conservative estimation, so we just looked at the cost of treatment, the devices, the need for hospitalization, so we didn't assume that by using the 780G pump, this would lead to improved pregnancy outcomes. And actually what we see is that by using the 780G pump in pregnancy, there is a cost saving of about 232 euros per individual compared to standard of care. So the 780 pump has a higher cost initially compared to what we used in the standard of care group, but this higher cost is offset by the fact that there are shorter and less frequent hospital admissions, mainly due to severe hypoglycemia and dysregulated diabetes in the 780G group compared to standard of care. A few months ago, we also published the data on the use of the 780G pump throughout delivery and early postpartum, and this was published in Diabetes Care. So for all women using the 780G pump, 62% continue to use the pump throughout delivery, and 86% use it in early postpartum, so the first days after delivery. And what you can see is that women using the closed loop system throughout delivery had a higher time in range, 71% compared to the standard of care, 63%. And postpartum, there was a high time in range, so the non-pregnancy time in range was more than 80%, both in the 780 group and the standard of care group. And very importantly, women who continue to use a 780 pump throughout delivery could just remain, the majority could just remain at a glucose target of 100 and an active insulin time of 2 hours. So this really indicates that the algorithm adapts fast to the decrease in insulin resistance immediately after delivery. And you can continue to use the pump both during vaginal deliveries and C-sections. There was an equally well-controlled glycemic control during delivery also in C-sections. You do need to increase, of course, the insulin to carb ratio immediately after delivery, on average with 67%, and more in women who are breastfeeding, on average 81% compared to 49% in women who are not breastfeeding. And here is an example. So the green dot is the time of birth, and she could just remain at a glucose target of 100, an active insulin time of 2 hours, and you see a very stable glycemic control after delivery without hypoglycemia. She was giving half breastfeeding and half formula feeding, so the insulin to carb ratio were only slightly increased. So it's very reassuring for women that they can just continue with the pump also throughout delivery and early postpartum. So to conclude, the KMAPS system is the first AID system licensed for use in pregnancy and has demonstrated improved glycemic control compared to standard of care. But there are many closed-loop systems available, so it's also important to have evidence on closed-loop systems that are not officially approved for use in pregnancy. So we have demonstrated that with the Minimed 780G system that this can safely be continued throughout pregnancy and also throughout delivery and early postpartum. It provides some additional benefits compared to standard of care, so improved glycemic control overnight, less time below range, and improved treatment satisfaction. And in women who were already well controlled at the start of pregnancy, so with a baseline hemoglobin A1C below 7%, it also leads to significant higher time in range, so 5% difference with the standard of care group. And also in women who were not already using a closed-loop system before pregnancy and had a lower education, switching to the 780G pump leads to improved glycemic control, and it also has a high potential to be cost-effective when used in pregnancy. So I want to thank all the different researchers, the different centers, the participants, of course, and also my PhD students. I thank you for your attention.
Thank you, Professor Catherine, for a wonderful presentation. I think we're going to have question answers at the end of session. Now we move on to the next speaker, and it's a pleasure to introduce my friend, Professor Tatiana Milenkovic. She is a professor of internal medicine at Faculty of Medicine at St. Cyril and Methodius University of Skopje, Macedonia. She has been president of Macedonia Diabetes Association since 2013, and since 2014 she has also been the president of Macedonian Scientific Association of Endocrinologists and Diabetologists. She was recently elected the president of Diabetes Education Study Group, which she will be there till 2027. She is a member of the IDF Europe Board of Directors also. Welcome, Tatiana.
Respected Chair, thank you for kind invitation, dear colleagues. It is real my pleasure to be here with you. But I have to say at the beginning, unlike our first speaker with so many data, I somehow envious you. There is quite another situation with pregnancy and type 2 diabetes, but I will do my best to give you some data about the problem of CGM and pregnancy complicated with type 2 diabetes. This is my disclosures, and I wanted to start with just a brief history of glucose monitoring, which dates back a long time, but especially from the middle of last century with glucose monitoring in the urine, then to glucose meters, glucose sensors, and real-time measuring, and through some old glucometers, and now a different type of CGMs which are appearing at the market every year in a bigger and bigger number. So this is exactly this slide shows what is the CGM use over time. So we can see clearly that since 2011 to 2018, the use of CGM raised more than 30%. And from the other part of the slide, you can see the comparison between CGM use in 2010 to 12, which was around 7%, versus 30% overall in 2016-2018, and especially in those with youngest, up to 13 years of age, but also the CGM use raised in those over 50, which is quite normal because the population of type 1 is getting old. And this is especially related to type 1 diabetes. And why it is so much important, this CGM use, that I think that make a real revolution in the treatment of type 1 diabetes, especially. Here, this trials very clearly shows that the first column is the level of HbA1c in those in 2016 to 2018 in those who were just on insulin treatment. And then there was a slight improvement with the pumps, but not enough. But the real improvement appeared when the injections were combined either with CGM, CGM was combined either with multiple injections or pumps. And really, it was a real revolution, and patients with type 1 were able to achieve the best level of glycemic control with less complication, what wasn't the case without the use of CGM. So this is very, the effect of CGM is very well established in type 1 diabetes, but it is unfortunately less clear in type 2 diabetes. So this is one meta-analysis that I am showing, which is quite recent from last year. It analyzed 12 trials with more than 1,200 patients, and it shows that CGM was associated in people with type 2 diabetes with improvement in HbA1c and in other metabolic parameters in these people with type 2 diabetes. And this was irrespective of the type of treatment, of age of participants, and also of baseline HbA1c. But there was not enough data to confirm that CGM was beneficial of lowering incidence of hypoglycemia and lowering incidence of late micro and microvascular complications in these people with type 2 diabetes. So what is the prevalence of pre-gestational type 2 diabetes? It is developed, it is rising, especially in developed country. We have data from there, that it is increasing from 0.6 to 1.5%, and it's increasing continuously. And this is in particular type 2 diabetes prevalence, which increased up to 1.06 in pregnancies between 1995 and 2012 in UK, and with that it overtake the incidence of pregnancies complicated with type 1 diabetes. So also this recent Australian trial reported 11.69% increase annually over a decade, and now the pregnancies complicated with diabetes are almost 1% of all births. It is also very well known that the women with type 2 diabetes in pregnancy have worse maternal and fetal outcomes compared to the general population, and these outcomes are quite comparable with those with ladies who are pregnant with type 1 diabetes. But despite that we know this fact, there is really a quite limited number of studies which are looking into the effect of CGM in type 2 diabetes compared to the so many trials that our previous speaker shows what is the situation with pregnancy complicated with type 1 diabetes. So these are the goals of blood glucose in pregnancies, especially those which are followed with CGM, and it should be the time in range below or higher than 70%, below 3.5 millimole less than 4%, below 3 millimole per liter below 1%, and finally time above range, above 7.8 millimole, less than 25%, which is really quite difficult to achieve without CGM. So I found this trial quite interesting. It's recent trial and data that are coming from UK. And you can see from that part of the slide what is the influence of early pregnancy level of HbA1c or on serious adverse pregnancy outcomes. And it is understandable that the higher level of early pregnancy HbA1c is associated with more maternal and also childhood outcomes. But what is interesting at this part of the slide, at the last column, you can see at 2021, especially recent years, there is a better preparedness of those with type 1 diabetes in early pregnancy, and we can see this gap between early pregnancy level of HbA1c in women with type 1 diabetes, which is quite better than those in type 2 diabetes, and this is probably related to CGM measurement, and these ladies are more prepared for the pregnancy at the same beginning, what is not the case with women with type 2 diabetes. But despite the CGM, as we saw at the previous talks, that just the hybrid closed-loop systems are followed with better outcomes in pregnancies. You can see that 95% of mothers in general population have successful live-born babies, which is not the case with pregnancies complicated with type 1 and type 2 diabetes, so many obstetric and neonatal complications related to maternal glycemia affected 1 in 2 pregnancies with type 1 diabetes and 1 in 3 pregnancies affected with type 2 diabetes. So we still have more severe and not expecting outcomes in pregnant women with both types of diabetes. So, what are the trials of use of CGM during pregnancy in women with type 2 diabetes? Of course, the data are quite less robust than those we are seeing in pregnancy complicated with type 1 diabetes. And to date, there is no randomized controlled trial which looks specifically in use of CGM and its benefit in women or in pregnancies complicated with type 2 diabetes. So this is the summary of key studies with mixed population of women with type 1 and type 2 diabetes. As you can see, there is just four trials, and the number of women with type 2 diabetes is significantly lower, or there are less women with type 2 diabetes in this population. So in the first one, in Murphy trial, which is, we can see the only positive trial, is only 35% of women with type 2 diabetes and relatively small number of 46 women altogether. In second trial, this is just 20% women with type 2. In third, just 27. And in the last trial, Tuminia trial, there is just 6 women with type 2 diabetes and 15%. And this trial shows, it was a small number, but still shows a little better in terms of less glucose variation in this woman with type 2 diabetes on CGM, but there was no other improvement. So this is the sub-analysis of these trials, which are related especially to pregnancies complicated with type 2 diabetes. And we can see just the first trial, the Murphy from 2008 from UK, it shows that in this woman with CGM, during the pregnancy, there was continuous improvement in glucoregulation in HbA1c and other parameters. Especially, it come to the significance to the end of the second and beginning of the third trimester. So in this trial, we can see the higher time in range in this woman, then the lower time above and below range, lower mean glucose and lower HbA1c, which reach significance at the third trimester of the pregnancy. So in these two other trials, which are newer trials, there was no differences in metabolic control, but also no differences in parameters regarding the newborns or macrosomia, which are seen very often in women with in pregnancies complicated with both types of diabetes. And this is the last Murphy trial, and from that side of the slide you can see that there was improvement in HbA1c, which was significant at the end of the pregnancy, and of course significant lower number of infants with macrosomia in this woman, in both women, in both types of diabetes, but especially in those with type 2 diabetes and pregnancies. So I want to, at the end, to tell you about one study more, which I find it very interesting, because this study is look into a visibility and acceptability of intermittently scanned CGM for women with type 2 diabetes in pregnancy. It was a rather small trial, just 57 women, and 50 or 88% out of them, they fulfill or completed the satisfaction questionnaire, and just 79% of these women used CGM for more than 2 weeks. So the mean sensor use at this trial was, these women was 12 weeks, and just 40% of all of them started to use the sensor at the first trimester. So majority of these women started to use CGM in a later course of pregnancy, which is not the case with type 1, as we can see. So in the final 2 weeks of pregnancies of this woman, the mean sensor activity time was about 60%. The mean number of scans per day was about 4.3, and the proportion of women with sensor activity more than 75% was just 27%. So this is completely different of data that we can see in pregnancies complicated with type 1 diabetes, because the majority of these women with type 2 diabetes, or maybe all, are starting using CGM at the very beginning of their pregnancy, and in the first trimester, and more than 70% of them had sensor activity more than 75%. So, which is vital for precise control of their diabetes during the whole pregnancies. And they were asked to fulfill this questionnaire, and if you can see, this is the most interesting, that even more than half of these women, they said that it was too annoying for them to be aware of their diabetes in every moment. So it seems that there was too many information for this woman, maybe because they were on a less complicated regimes that the type 1 women are on multiple daily injection. Maybe that was the reason, but however, the use of CGM was not enough to show some benefits on the outcomes of the pregnancy of this woman. So I can conclude that up to date there is insufficient data to support the use of CGM in all women with type 2 diabetes. I mean, the decision or whether we will use CGM in pregnant individuals with type 2 should be individualized and based on our treatment plan, on different circumstances, of course, on preferences and wishes of women with type 2 diabetes. But of course, that not just mine opinion, the CGM is and can be a quite useful and very well received tool if we explain and educate this woman with type 2 diabetes how effective it can be. And of course, use of CGM in pregnancies complicated with type 2 diabetes can improve glycemic control in women with type 2 diabetes and pregnancy, but still we need other rigorous studies, well-controlled randomized trials, just to confirm that impression that we have that CGM absolutely can be effective tool in improving outcomes of pregnancy in women with type 2 diabetes. And with that, I would like to thank you for your attention.
Thank you, Doctor. The question finished, all the speaker. I introduce to you Dr. Ashley Batterby, is an associate professor in the Division of Maternal Fetal Medicine at the University of Alabama in Birmingham. She is currently the principal investigator of 2 multi-center randomized clinical trials. One of them is evaluating the effectiveness of continuous glucose monitoring for management of type 2 diabetes in pregnancy. Is a director of a Center of Pregnancy program to provide integrated multidisciplinary care for patients with diabetes in pregnancy. Welcome, Doctor.
Thank you. Thank you to IDF for the invitation to speak on CGM in gestational diabetes. Here are my disclosures. So our objectives for the rest of this morning are going to be to evaluate the evidence for CGM for use in the management of GDM, to then analyze the relationship between CGM metrics and adverse outcomes in GDM, and then finally to discuss some emerging applications of CGM to diagnose GDM and then also to screen for glucose intolerance postpartum after a pregnancy complicated by GDM. We all know that hyperglycemia is one of the most common medical conditions that women encounter during pregnancy. It occurs in up to 1 in 6 live births, the majority of which are due to GDM. This is clinically important because hyperglycemia and GDM is associated with an increased risk of maternal morbidity and mortality, as well as perinatal and neonatal morbidity and mortality, and also later long-term consequences for both mother and child. Finally, we know that GDM is on the rise globally, affecting over 20 million live births annually and disproportionately affecting low and middle income countries, making it a critical public health crisis. So while there are guidelines available around the world for the diagnosis and management of GDM in pregnancy, few specifically address the use of CGM in these patients. Here are the recent guidelines from the American Diabetes Association, which state that there are insufficient data to support the use of CGM in all people with GDM. CGM may be beneficial, and they suggest that the decision of whether to use CGM in pregnant patients with GDM should be individualized, again based on treatment regimen, circumstances, preferences, and needs, which we just heard previously with regards to type 2 diabetes. But what does the evidence say? We do have a little bit more evidence for GDM compared to type 2, but not quite as much as type 1. These are data from a systematic review and meta-analysis conducted by Garcia Moreno in 2022 that reviewed over 450 studies and found 6 RCTs that met inclusion criteria. And that had to be enrolling participants with GDM and randomizing them to using CGM or fingerstick testing and evaluating outcomes. In the table on the left, you can see that these studies were conducted in different countries around the world, but had relatively small sample sizes with total Ns of less than 150. And they also used relatively older generation CGM devices, many of which were masked or blinded to the patients and are less accurate than our newer devices available today. The results shown in the forest plot on the right indicate that the use of CGM did improve maternal glycemic control with lower hemoglobin A1C compared to fingerstick testing, but there were no significant differences in other outcomes such as preeclampsia. Additional data are provided by the recent time in range using CGM for GDM study, which was a single center RCT of Dexcom G6 CGM versus self-capillary blood glucose monitoring conducted at the Oregon Health and Science University in the US. In this RCT, they enrolled 111 participants who had GDM diagnosed by either the one-step or two-step approach and were carrying a singleton gestation at 20 weeks or later to assess the efficacy of real-time CGM to increase glucose time in range in pregnancy compared to capillary blood glucose monitoring. And here are their results. In the figure on the left, you can see that CGM use in blue increased time in range across the 24-hour period compared to capillary blood glucose monitoring in red. Additionally, on the right, they found that CGM lowered mean glucose again across the entire day compared to capillary blood glucose monitoring. For their primary outcome of time in range between 60 and 140 milligrams per deciliter, they found that participants randomized to CGM achieved a higher time in range of 93.6% compared to the capillary blood glucose group that only achieved 87.6% time in range, or a difference of approximately 6 percentage points. But I'll have you note that those time in ranges are much higher for participants with GDM than we've seen in the previous type 1 diabetes trials. Overall, these data support the meta-analysis that CGM in patients with GDM may improve maternal glycemic control compared to fingerstick testing. But what about other pregnancy outcomes? So starting with LGA, which we know is more common in patients with GDM, and particularly those with glycemic control. These are data from a prospective observational study of 162 pregnant women with GDM diagnosed by NICE guidelines. Participants wore a masked iPro2 Medtronic CGM for 7 days, and this was done once at 30 to 32 weeks gestation. The investigators used functional data analysis to evaluate the association between CGM data and LGA infant at birth. And what they found, not surprisingly, was that the mean glucose on CGM was higher in women who delivered an LGA infant compared to those who did not have an LGA infant. Furthermore, in the graph on the right, you can see the period of time with the greatest difference between those with and without LGA was overnight between midnight and 8 a.m., which further supports the use of CGM in pregnancy because otherwise this period of time is not captured by traditional fingerstick testing. What about other outcomes besides LGA? So these are data from a prospective observational study of 1,302 pregnant women with GDM from a hospital in China who wore a masked Freestyle Libre Pro, this time for 2 weeks, 14 days, at 26 weeks gestation. The authors used multivariable modeling to estimate the association between CGM metrics and adverse outcomes. The forest plots on the right illustrate their results, and they found that multiple CGM metrics, including time above range, mean glucose, daytime mean glucose, and nighttime mean glucose, was associated with an increased risk of a composite of any adverse outcome. You can see that that composite adverse outcome was driven primarily by LGA, where you see similar associations between all of these CGM metrics and LGA, as well as associations with time in range, time below range, and the mean amplitude of glucose excursion, or MAGE. They found that time above range on CGM was also associated with NICU admission, but there were no associations with preterm birth, fetal distress, or prom. And so these data suggest that in addition to CGM improving glycemic control, perhaps, although not proven yet, CGM may also improve other neonatal outcomes if that is driven by glycemic control. And then finally, we have data on adverse outcomes from the GLAM study, which I'll reference a few more times during this talk. The GLAM study was a prospective observational study of 768 pregnant persons without pre-existing type 1 or type 2 diabetes who were enrolled at less than 17 weeks and wore a masked Dexcom G6 Pro, this time continuously until delivery, whereas in the previous two studies, it was just for 1 or 2 weeks. The investigators then included participants who had at least 14 days of data, and in this analysis looked at the association with adverse pregnancy outcomes, including LGA, SGA, and hypertensive disorders of pregnancy, or HDP, which included gestational hypertension or preeclampsia. Here I'm going to focus on HDP. Their results for LGA were the same as the previous studies, and their results for SGA were actually the opposite, where lower blood sugar was associated with higher risk of SGA. But with regards to HDP, you can see in the top figure that the mean glucose across the 24-hour day was higher for participants who went on to develop HDP compared to those who did not have HDP. And then on the bottom figure, you can see that this difference started very early in pregnancy, as early as 13 to 14 weeks of gestation, and continued throughout the pregnancy. And we'll come back to that in a few minutes. So to summarize our first two objectives, there is promising RCT data that compared to traditional fingerstick testing, CGM improves maternal glycemic control during pregnancy, but there's limited data that directly evaluate the impact of CGM use on other adverse outcomes. I've shown you that there are multiple CGM metrics that are associated with adverse outcomes, such as LGA, SGA, NICU admission, and HDP, but whether or not the use of CGM compared to fingerstick improves these outcomes has yet to be shown. Additionally, it leads us to the question of what CGM targets should be used for GDM management.
Okay.
Should they be the same as those used for type 1 diabetes? Probably not. They should probably be a little bit higher, but what is that correct number? From the OHSU study, we saw that time in range greater than 90% can be achieved safely for patients with GDM. Additionally, should the targets be different for daytime versus nighttime, and which CGM metric is most helpful for management in pregnancy? So in order to answer some of those questions, I want to take a step back and try to understand what is normal. So in this analysis of GLAM study data, Carlson et al. Included participants who had a first trimester hemoglobin A1C of less than 5.7% and did not develop LGA, HDP, or GDM, approximating a normal pregnancy. And what they found was that the mean glucose of a normal pregnant person, if you want to kind of estimate normality, was 98 milligrams per deciliter, or 5.4 millimoles per liter. And this was relatively stable across the entire pregnancy. The percent time in the pregnancy-specific range of 63 to 140 was high at 94% overall, and again, consistent over pregnancy. Even using a tighter range of 63 to 120 milligrams per deciliter, the time in range was still high at 85%. And then accordingly, you can see that the percent time greater than 140, greater than 120, and less than 63 was very low. Here are these data shown across the 24-hour day, with the trimesters shown in blue, green, and red. And you can see just as there's little variability across the entire pregnancy, there's also relatively little variability across the 24-hour day. The investigators found that the average glucose around 5 to 6 a.m. was 93 milligrams per deciliter or 5.2 millimoles per liter, and the postprandial peak glucose, which occurred approximately 62 minutes after eating, was 126 or 7.0. And so these normative data provide some framework as to what CGM metrics we may want to try and target in patients with GDM. But then how do those targets differ between patients who do and do not develop GDM? So again, the GLAM trial provides us with some helpful data here. And here in this analysis, they only included data up until the point of GDM screening, which again was with either the one-step or two-step approach at 24 to 34 weeks, as they did not want to have any issues with bias with regards to GDM treatment. But you can see that the average glucose on CGM of participants who developed GDM was higher than those who did not develop GDM. And again, it was consistently higher across the 24-hour day. These are those same data summarized. So in the table on the left, you can see the mean glucose on CGM was higher in those with GDM at 109 milligrams per deciliter or 6.0 millimoles per liter. And then you can see that the time in range was lower for those with GDM at 87% versus 94% without GDM. And finally, the time above range, again, higher for those with GDM at 7% versus 3% without GDM. And then you can see the results with the tighter pregnancy target of 63 to 120. Again, lower percent time spent in this range with GDM than without, and higher time above 120. In the figure on the right, you can see the differences for percent time greater than 120 and the percentage of time greater than 140, with participants who developed GDM in red and those who did not develop GDM in blue. And again, similar to the data that I showed you with regards to hypertensive disorders of pregnancy, you see differences in hyperglycemia starting very early in pregnancy, as early as 13 to 14 weeks. So to summarize the kind of normative or normal CGM metrics in pregnancy, the average glucose is somewhere between 95 and 100 milligrams per deciliter, with very little variability throughout the day and across gestation. Approximately 95%, so very high percentage of the time is spent between 63 and 140, and very little time, only about 2% above 140. So because of this, experts have recommended more intensive CGM goals for GDM, with the kind of expert recommendation being less than 5% spent time above range, greater than 140, greater than 90% time spent between 63 and 140, the pregnancy-specific range, and then the same, less than 4% spent below 63. So we saw that there were differences in CGM metrics in patients who went on to develop GDM compared to those who didn't, and it started very early in pregnancy. So this begs the question of whether CGM could actually be used early in pregnancy to predict later GDM. So this is a prospective observational study of 103 multi-ethnic Asian pregnant women with overweight or obesity in Singapore who wore a masked Freestyle Libre Pro CGM for 14 days between 11 and 13 weeks with an average of 12.2 weeks gestation. They completed a 2-hour 75-gram GTT later in pregnancy during the recommended time of 24 to 28 weeks using IID-PSG criteria for GDM diagnosis. And they found that 18 women, or 18%, were diagnosed with GDM. So using some regression modeling with forward selection, they arrived at 4 different CGM metrics in terms of their predictive ability to later predict GDM. And those 4 CGM metrics were the coefficient of variation, CONGA, GMI, and MAGE. And what they found was those metrics performed much better than clinical risk factors like age, ethnicity, BMI, and blood pressure, with an AUC for the CGM metrics of 0.95 compared to 0.72 for clinical factors. The GLAM team also did a similar analysis evaluating the ability of CGM to predict GDM. And so, again, for this analysis, they only included CGM data up until the time of OGTT. And they found in their study that 55 or 7% were diagnosed with GDM. Of the multiple CGM metrics that they evaluated, the percent time above range, above 140 or 7.8, was the best predictor and had a relatively high AUC of 0.81 for the prediction of later GDM in pregnancy. And then when they did a sensitivity analysis restricting only to the 13 to 14 week CGM data, they found that the prediction was still relatively good with an AUC of 0.74. So it seems like there could be some utility in using CGM to screen for and diagnose GDM in pregnancy, but what does this look like in practice? So investigators from the University of Texas Health Science Center at Houston just recently completed an RCT of CGM versus OGTT for the diagnosis of GDM with the primary aim of improving perinatal outcomes. They enrolled a total of 814 pregnant women who were carrying a singleton gestation at 24 to 30 weeks and randomized them to either GDM screening using a CGM or to the traditional OGTT testing. And this was done at the kind of routine time period of third trimester GDM screening, again, between 24 and 30 weeks. And so for participants who were randomized to CGM screening, they wore a Dexcom G6 Pro for 7 days, and based on some pilot data, they diagnosed patients with GDM if they had 10% or more time spent greater than 140, a mean glucose of greater than or equal to 130, or any value greater than or equal to 200. And then for the routine screening, they were diagnosed with GDM if they had 2 or more abnormal values on the 3-hour OGTT using Carpenter-Coustan criteria. And they found that using CGM to screen for and diagnose GDM resulted in a higher incidence of GDM diagnosis compared to the routine OGTT testing, and there was no reduction in the composite neonatal outcome. So essentially, I think there's more to come for CGM on GDM diagnosis. The GLAM team actually just published a paper last week where they used CGM actually during the OGTT, and so check that publication out. I didn't have quite enough time to include it here. So last, we know that 1 in 2 women with GDM will develop type 2 diabetes within 5 to 10 years after delivery. So it's critical that we not only focus on pregnancy management to improve short-term outcomes, but also impact long-term health, which starts with postpartum screening for persistent dysglycemia. Unfortunately, it's a really challenging time for patients to come back for follow-up, and up to half of patients with GDM do not complete recommended testing postpartum. So in order to try and overcome some of the barriers to postpartum diabetes screening, there have been a few small pilot studies that have investigated the utility and feasibility of CGM rather than the traditional OGTT. This first study was a pilot observational study by our team that looked at women with a history of GDM with the aim of evaluating the association between CGM and OGTT for postpartum diabetes screening. Participants wore a masked Dexcom G6 Pro for 10 days and completed a 75-gram, 2-hour OGTT at 3 different time points postpartum: immediate, occurring in the hospital less than 48 hours after delivery, 6 weeks, and 6 months postpartum. These preliminary data were presented at the SMFM 2024 meeting and included analysis of 32 participants who had the CGM and OGTT at 53 visits. 27 were immediate, 20 were at 6 weeks, and 6 were at 6 months. And what we found was that the average glucose on CGM was associated with OGTT results at each of the study visits. So for every 10 milligrams per deciliter increase in average glucose on CGM, or 0.6 millimoles per liter, there was an increased odds of 1.83 of a worse diagnosis by OGTT. So what this means was for every 10 milligrams per deciliter increase in average glucose, the odds of having pre-diabetes versus no diabetes was 1.83, and then the odds of having type 2 diabetes versus pre-diabetes, again, 1.83 using ordinal logistic regression. We also found that as blood sugar is higher on CGM, there's a lower odds of having a completely normal OGTT, a higher odds of having type 2 diabetes by OGTT, as well as higher fasting and 2-hour glucose values on your OGTT. So seems promising that the CGM is associated with the GTT results. Similarly, there was another prospective observational study of women with GDM conducted to evaluate the feasibility of CGM to detect postpartum dysglycemia. Here, participants had a Dexcom G6 Pro CGM placed at 1 to 3 days postpartum, which they wore for 10 days and then returned to the study team. They were encouraged then to follow up for their 6-week OGTT as part of standard of care. Of 50 participants enrolled, 86% returned the CGM and 66% completed the OGTT. On CGM, the average glucose was 122 milligrams per deciliter, and then of those who completed the OGTT, 21% had impaired glucose tolerance and 1% had overt diabetes. And in their analysis, they found that greater than 4% of time spent greater than 180 was the best predictor of dysglycemia on OGTT, which was defined as having either impaired glucose tolerance or diabetes, and had relatively good test parameters with sensitivity and specificity of about 85%, positive predictive value of 60, and negative predictive value of 96%. But of course, these are 2 very small pilot studies, so more is needed with regards to postpartum screening after GDM. So we've covered quite a bit. I think there's still maybe more unanswered questions than questions that we answered today, but also really some cool studies coming soon. I think some of the key questions that still need to be answered is CGM beneficial for pregnant persons with GDM, specifically focusing on the clinically relevant maternal and neonatal outcomes, as well as what CGM metrics should be used for GDM management with evidence based on those outcomes. We know that there are many trials. These are just a few of the countries that I saw either ongoing or planned trials of CGM for patients with GDM coming up. We have some studies that have already been completed that we're awaiting publication. The MAGIC trial, which was very similar to the GLAM trial in design. GOMOMS, a very large study of over 2,000 pregnant persons, which will provide some more normative data, as well as the IMAGINE trial, which is going to combine, which is getting started now, which is a collaboration between the GLAM and MAGIC investigators, which is going to look at CGM for early screening for dysglycemia in pregnancy. And then after that, I think we have to understand, is CGM cost effective? Can it be used for some of these other applications, so screening and diagnosis during pregnancy or postpartum? And then finally, if it is beneficial and is cost effective, how do we equitably implement CGM use for GDM? So thank you so much for your time, and I look forward to question and answer.
Okay, is there any question to the audience?
We can have all the speakers here.
Please.
Hello, thank you for your esteemed presentation. I'm Simon from Global Diabetes Association, Iran. I have a question for Dr. Ashley Batterby. I was wondering, in so many of your studies regarding management of GDM, attendees used masked CGM probe. I was wondering why, because you see, wearing the CGM for the patient is insightful and affect the way they manage their diabetes. But when they're using the masked type of the CGM, they couldn't see the fluctuations in their blood glucose. And I was wondering why this type of CGM was chosen. Thank you.
That's a great question. So some of the studies that I presented, the CGM data was being collected solely for research purposes and not for management, and so that's why they chose the masked CGM, like the GLAM study, for example. Some of the early trials also used masked CGM, but I agree with you 100%. When we're using it clinically, we're using the real-time CGM so that patients can see their data and respond in real time with lifestyle changes and whatnot.
Please, Dr. Dr. Sasber, please tell your name and where are you from?
Thank you very much. I am Shabin Nazmasood, Professor of Obs and Gynae in Pakistan. My question is to all three speakers. Very nice presentation, in fact. My question is regarding the use of CGM for 40 weeks of pregnancy. What do you generally recommend? Obviously, CGM cannot be placed, or sensor cannot be placed for all 40 weeks of pregnancy. So what do you suggest for each trimester of pregnancy? What period of time should a woman wear CGM, the sensor, in order to diagnose or exclude gestational diabetes type 1 or type 2 monitoring?
I think for type 1 diabetes, it's been clearly shown that you have to use it continuously, because otherwise intermittent use was not associated with improved control. So if the means are there, and I think that's what most associations recommend, is really to offer CGM to all women who want to become pregnant and use it continuously. As your two other speakers mentioned, in GDM, the evidence is not there yet that it can improve pregnancy outcomes, but we know that from the studies so far, it was smaller studies, often with intermittent use. So I think it will be interesting to see the large RCTs where they use it continuously before we know what to do. Concerning diagnosis, much more evidence is needed, and you've seen the large studies ongoing. So we really need more larger numbers. I mean, the GLAM study was great, but only 7% developed GDM, so it only small numbers. So I don't think we are there yet to use it in practice.
Yeah, I agree completely. I would use it continuously for someone who has GDM if you can get it and it's available.
Yes, it's the same with type 2 diabetes. We just have few studies with intermittent use, not continuous use during the whole pregnancy.
Well, first of all, I want to congratulate each one of you because of the excellent presentations. I wanted to ask if how many patients, if any, reject using a sensor during pregnancy, and especially in the 4th trimester?
I can tell you about type 1 diabetes, none. I mean, if they want to become pregnant and they are pregnant, they are very motivated. And again, we have a situation where it's reimbursed anyway for all people with type 1 diabetes. So I'm well aware it's not the case in many parts of the world. Also, in type 2 diabetes, we can offer it to women using multiple daily injections. We can offer CGM as well to type 2 diabetes. And so certainly when there is pregnancy wish or they are pregnant, they are very motivated. It's rare that they refuse it. For GDM, we don't use it yet in normal clinical routine. We are doing a large study evaluating it also in women with early GDM because there's not much data there. So I think in general it's well accepted, but again, it can also be perceived as a burden. So we are investigating also patient treatment satisfaction and the burden of it, because especially in GDM, it's much easier to already achieve good glycemic control even with SMBG. So indeed, it is important to have data also on the burden.
And in gestational diabetes?
Also in type 2 diabetes, it depends on insulin regime. It is much easier to introduce the CGM in those who are on more complicated regimes like basal bolus, but those who are well controlled with small doses of insulin on even without any treatment, then maybe it will be some level of reluctance to use this, because as you said, from the final trials, they are finding that they are getting too much information that even concern them too much, that they wouldn't like that during the pregnancy.
Yeah, I would speak for our patients with type 1, type 2, and GDM. It's very rare for someone to not be accepting of a CGM. I think one of the probably most common reasons that we'll have a patient who doesn't want one is someone who's had really bad allergic reactions. But as we're getting, more adept with more tips and tricks on how to prevent that, I think it's becoming less common. But I think when it first started becoming more prevalent, we were worried that people wouldn't want a wearable sensor that other people could see, and we actually find that that's not the case most of the time. Patients really enjoy not having to do finger sticks anymore, so uncommon.
Thank you very much.
Okay, I have a question first. Is it safe to use the CGM in pregnancy? Does it also require to check RBAs by using glucometer in pregnancy?
I think there is enough data now that it can be accurately used in pregnancy, and that in principle no finger stick checking is needed anymore, unless there can always be a technical error, and of course then they need to do it. But otherwise, I mean, the sensors used in the studies are all well approved for use in pregnancy.
So we can have a question there.
Thank you for that earlier question, because it's related to my question. Good morning. My name is Dr. Lizette Lopez from the Philippines. And I would also like to ask about the accuracy, because although it seems from the studies that you sort of presume that it's accurate compared to a capillary blood glucose, when we're talking about, I was wondering about the sort of the nuances of using interstitial glucose through CGM, especially with Freestyle Libre, which is more common in my country. Dexcom, I know, is supposed to be more accurate. Unfortunately, it's not available in the Philippines. And as a result, because on the ground, we've been seeing wide or sort of these discrepancies where it can even go as wide as 30 to 70 milligrams per deciliter, especially in pregnancy. So would you have the data on that, or would you have any information?
There were some issues with the Freestyle Libre 1. So the intermittent scanning, especially, it gave some lower glucose values, especially overnight, when compared to other systems. Now, the next generation's Freestyle Libre, the 2 and the 3, we don't see any major accuracy issues. And it's also continuous glucose monitoring now. But again, with the Freestyle Libre 1, there were some issues. So I don't know what you have available, but the next generations should be okay.
Yeah, it was Freestyle Libre 1 before, and now we have 2, so hopefully
it should be okay. It should be okay, yeah.
Thank you.
So there's one question online. Those who are wearing CGM, do you see any differences peripartum in women who are going for normal delivery versus the C-sections? Have you found any differences in the glucose levels?
I'm not aware of any specific studies that compared accuracy with vaginal delivery or C-section, but anecdotally, in looking at our patients that we take care of, I haven't noticed any particular differences between vaginal delivery and C-section, and I think probably shown in some of the postpartum data in type 1.
So there is another question.
With the closed loop systems also, we continue it throughout delivery, and the glycemic control is equally adequate with C-sections than with vaginal deliveries.
You don't find any difference in the requirement of insulin?
No, you can continue it both in C-sections and normal deliveries, yeah.
So there is another question on AID, that intrapartum data continuing AID looks great. There's some anxiety around diathermy used during C-section in people who are on, AID. So what's your comment on that?
So, yeah, I mean, women could, of course, when we started the study, we had no idea how the algorithm would adapt, right? So at first we were careful, but actually the first participant in the study was delivered using the AID system, and it went really well. And from there on, we propose it to all women, actually, whether they have a C-section or a normal delivery, they can continue with the closed loop system. And most women are very happy, and also the obstetrical staff are very happy, because they can just leave the pump and have the pump do all the work or most of the work. So whether it's during C-sections, it's not a problem. You just have to make sure that the sensor and the pump are way out of the field of the operation, but otherwise there is no technical issue.
So we have a couple of more questions from the floor.
I'm Loman from Malaysia. I have a question about the fake cups in the crystal trial. I posted in the chat, but I just want to add a bit more. The first part is that if you add a fake cup by 50%, right, would that be the same as reducing the ICR by 1/3?
No. So this is really very specific for the 780G system only, is the safe meal bolus. So it's a safety feature of the algorithm, so it will reduce the bolus when it predicts hypoglycemia within the next 4 hours, and it's dependent on the total insulin dose and the predicted evolution of your glycemia. But by further reducing the insulin to carb ratio, it will just further reduce the bolus. So the only way to handle it, and we learned this in the study, is often it's better to slightly increase the ratio again to limit the risk for safe meal bolus. But with slightly, I mean, for instance, ratio 5 go to 5.5. So it's really a slight increase. And at the same time, recommend women to add fake carbs. And generally, I start with 50%, see what the effect is. At the end of pregnancy, when there is a lot of insulin resistance, of course, I have had women who even had to add 200%, even 300% fake carbs. So it really is a way to just have the algorithm to provide enough bolus without risk of hypoglycemia. So you can be quite aggressive, certainly later on in pregnancy. Yeah.
Thanks. The second part is that, do you add fake carbs in between meals or not?
We recommend to do it with meals, preferably.
Okay,
yeah,
thanks.
with meals.
Hello, I'm Dr. Tahania Haq. I'm an endocrinologist from Bangladesh. So my question is with hypoglycemia. We know there's a lag time between the CGM interstitial glucose and the finger prick test. So in case of pregnancy, we don't want the hypos in their pregnant women. So what's your thoughts on that? Should we advise patients to check their finger stick test too, or just rely on the CGM?
In general, they can just rely on the CGM. Yes, there is a lag time, and you see the evolution, and you know if it's going down or not. Do they feel anything? Again, sometimes it's falsely low, especially overnight. If they lay down on the sensor, it can be falsely low. So if there is any doubt, yes, they can check it, but in general, it's not necessary to systematically have finger sticks when it's going down. The CGMs are quite accurate. But of course, you need to take into account the lag time. Yeah. Thank you.
I'll add in another thing with regards to hypoglycemia and the CGM, and this is true in pregnancy and non-pregnancy. It is nice to use the trend arrows so you avoid over-treating hypoglycemia, which you don't have the capability of doing with just the finger stick. We do similar things in our practice where if symptoms are out of range with what the CGM is reading, we'll recommend checking a finger stick, but otherwise, in general, find that they're fairly accurate.
I think we have an expert sitting here in the audience. We are honored to have Professor Satish Garg, who has been pioneer in technologies in diabetes. So I would request Professor Satish Garg to give his message or take home for this whole session.
Well, thank you for asking me. The three speakers did an amazing job. There is no doubt in my mind that CGM is becoming an important tool in all aspects of life, and especially during the pregnancy. Undoubtedly, in everybody with type 1, we use it routinely at the Barbara Davis Center for Diabetes. And we have done a lot of trials with using AID systems. There are different systems. They might pose some different challenges during the pregnancies, but really only few systems allow you to reach the targets that should be achieved during the pregnancy of 63 to 140 milligrams per deciliter. So long-term data are needed. As Ashley pointed out, there are a lot of studies that are ongoing which will probably prove the job. But you all three did an amazing job. Thank you.
Thank you, sir.
Okay, is on time?
Yeah.
I thank you, three speakers, for the presentation, and thank you for all us, and bye-bye.
Let's have a big round of applause for all three.